Hello, everyone, and welcome. So today we're going to tackle a really important topic, a disease that I promise you will see every single day in your clinical practice, in the wards, in the OPD, in the ICU. It's everywhere. We're talking about chronic obstructive pulmonary disease, or as we all know it, COPD. Honestly, understanding this condition inside and out is absolutely non-negotiable, both for your exams and for being a good doctor. So let's get right into it. So why is this so important? Why am I stressing this so much? Well, this slide tells you everything you need to know. According to the WHO, COPD is the third leading cause of death in the world. Just think about that for a second. The third biggest killer on the planet. The burden of this disease is just immense, not just globally, but especially for us here in India. This is exactly why we need to have a rock-solid understanding of it. Okay, so here's our plan for today. We're going to break it all down step by step. First, we'll talk about why COPD is such a huge problem in India. Then, we'll get into the exact definition of the disease. After that, we'll look at its two main types, chronic bronchitis and emphysema. Then, we'll cover the main causes or risk factors and dive deep into what's actually going wrong inside the lungs, the pathophysiology. And finally, we'll see how all of this creates a vicious cycle of damage. This is our roadmap. Right. So in India, COPD is a bit of a silent epidemic. The number of cases here is incredibly high, and it's a massive public health headache. But why? Well, for our country, there are a few key reasons. First, you have smoking, of course, especially BD smoking, which is super common. Second, there's the increasing air pollution, particularly in our big cities. And number three, and this is so important for the Indian context, is the use of biomass fuel in rural areas. We're talking about the smoke from burning wood, cow dung, and using those traditional chulas. You put all of that together and you've got a perfect storm for COPD. Okay, now let's get to the formal definition, and I want you to really focus here because define COPD is a classic exam question, both for vivas and for your theory papers. But more than that, if you truly get this definition, you'll be able to easily tell it apart from other lung diseases like asthma or bronchiectasis when you're seeing patients. So this is one you really need to know by heart. So this is the official definition from the GOLD guidelines. Let's break it down because every single word here matters. First up, it's preventable. That's good news, right? It means we can actually stop it from happening if we control the risk factors. Second, it's treatable. We might not be able to cure it, but we can manage it and give the patient a better quality of life. Now look at this, persistent respiratory symptoms. Persistent. That means the symptoms are there day in, day out. They don't just come and go. And here's the core of it all. Airflow limitation. An obstruction that is not fully reversible. Please remember that phrase, not fully reversible. The damage, the blockage, it doesn't just go away with an inhaler. And this slide is super helpful because it clears up something that confuses a lot of students. COPD versus asthma. What's the main difference? It all comes down to one word, reversibility. In asthma, the airflow problem is largely reversible. You give a bronchodilator, the airways open up, and the patient feels a lot better. But in COPD, the limitation is progressive. It gets worse over time. And like we just said, it's not fully reversible. Another big clue is the age. Asthma usually starts in childhood, while COPD is a disease of older adults, typically showing up after age 40. Okay, so under this big umbrella of COPD, we have two main conditions. You can think of them as the two classic faces of the disease, chronic bronchitis and emphysema. Now, it's really important to know that most patients aren't just one or the other. They usually have a bit of both. But just to understand it clearly, we'll look at them separately. So here's the main difference, and you need to get this straight. In chronic bronchitis, the problem is in the airways, the big breathing tubes. There's chronic inflammation, which makes the mucus glands, these goblet cells, go into overdrive and produce tons and tons of phlegm. But in emphysema, the problem is deeper. It's in the alveoli, those tiny little air sacs where the oxygen actually gets into your blood. Here, the walls of these sacs get destroyed and permanently stretched out. Now, for a simple way to remember the classic patient types, B for bronchitis, B for blue bloater, because they can look a bit blue from the lack of oxygen. And for emphysema, think P for pink puffer, because these patients are often seen puffing, breathing through pursed lips. And here you can see the classic pictures. The blue bloater, our bronchitis patient, has that classic productive cough with a lot of sputum. They might have cyanosis, that bluish color, and often have swollen legs or edema from right-sided heart failure. On the other hand, the pink puffer, our emphysema patient, is all about severe breathlessness. They're doing that pursed lip breathing, they have a big barrel chest from trapped air, and they're usually quite thin because it takes so much energy just to breathe. Interestingly, their carbon dioxide levels can stay pretty normal until the disease is very advanced. All right, let's talk about what actually causes COPD. Remember that first word in the definition, preventable? This is such a powerful word. It tells us that if we can just control these risk factors, we can stop this horrible disease from ever starting. So from a public health point of view, this section is maybe the most important one. This chart makes it pretty clear, doesn't it? The number one villain, the main culprit behind COPD, is tobacco smoking. It's responsible for about 3/4 of all cases. But, and this is a big but for India, look at that second slice. Biomass, fuel, and pollution. That chulha smoke. This is a huge, huge cause of COPD in our country, especially for women in villages. The rest is mostly from city pollution and dusts you might breathe in at work. So, here's your practical takeaway. When you see a patient over 40 with a chronic cough or breathlessness, you must ask about their exposures. For smoking, don't just write smoker. You have to calculate the pack years. That's just packs per day times the number of years they've smoked. Anything over 10 is significant. Also ask about chulha smoke and their job. Are they a coal miner, a textile worker? And for your exams, don't forget the rare genetic cause, alpha-1 antitrypsin deficiency. If you see a young person with severe emphysema who doesn't smoke, you have to think about this. Okay, now we're going to get into the really interesting stuff, the pathophysiology. This is how the damage actually happens. We're going to see what that cigarette smoke or chulha smoke is doing at a cellular level that causes such permanent destruction inside the lungs. If you can understand this cascade, you can understand the whole disease. Let's walk through this step by step. First, the person inhales toxins from smoke. This is like an enemy invasion. The body's defense system, in step 2, sends in the army, inflammatory cells like neutrophils and macrophages. In step 3, these cells start throwing out weapons to fight the enemy. These weapons are powerful enzymes called proteases, like elastase, that are meant to destroy invaders. Now, normally, our body has its own peacekeepers, anti-proteases, to make sure these weapons don't damage our own tissues. But here is the central problem, step 4. Smoking not only calls in more soldiers with weapons, it also takes out the peacekeepers. This creates a critical imbalance. So now, these destructive enzymes are running wild, which leads to step 5. They start chewing up the alveolar walls, causing emphysema, and they trigger the airways to produce tons of mucus, causing bronchitis. This concept, the protease-antiprotease imbalance, is the absolute key. If you remember that, you've understood the core pathology of COPD. So all that damage we just talked about, what does it actually lead to? What are the final functional problems for the lungs? Well, it all boils down to 2 major issues that feed off each other and create this terrible, vicious cycle for the patient. The first major problem is air trapping. You see, in emphysema, all that destruction of the alveolar walls means the lungs lose their natural elasticity. Think of a healthy lung like a new rubber band. You stretch it when you breathe in, and it just snaps back on its own when you breathe out. But a lung with emphysema is like a really old, stretched-out rubber band. It's lost its spring. Because of this, the small airways collapse when the person tries to breathe out. So what happens? The old, stale air can't get out. It gets trapped inside. Over time, this leads to the lungs becoming overinflated, which gives that classic barrel chest appearance. And the second major consequence is gas exchange failure. It's pretty straightforward, really. The alveoli are where the magic happens, where oxygen gets into the blood and carbon dioxide gets out. For this to work well, you need a huge surface area. In a healthy person, it's about the size of a tennis court. But in emphysema, when those alveolar walls are destroyed, you're losing that surface area. The result is simple and devastating. Less oxygen gets in, which we call hypoxia, and the body can't get rid of carbon dioxide properly, which we call hypercapnia. This failure of gas exchange is what causes almost all the symptoms, the breathlessness, the fatigue, everything. So to wrap it all up, here is your exam pearl. This is the classic story you will hear over and over again. A 65-year-old man from a village, a beady smoker, comes to you. He says he's had a cough with phlegm for the last 5 years, and for the past 2 years, he's been getting more and more breathless. When you hear that history, the first thing that should jump into your mind, your number one diagnosis has to be COPD. Burn this picture into your memory, because knowing this stuff isn't just about exams. It's about being able to help the countless patients you're going to see for the rest of your career. Thank you. All right, welcome back, everyone. So in our last explainer, we really laid the groundwork for what COPD is. But today we're moving from the textbook to the clinic. We're going to do this like a real bedside clinical round, following a patient's story right from their very first complaint all the way to a final confirmed diagnosis. So let's get started. Okay, let's dive right in with a case you will see time and time again. Let's meet Mr. Sharma. He's 60 years old, he's been smoking for a long time, and he's here today because he's got this nagging cough. It just won't go away. This is, without a doubt, the most classic presentation. So following his journey is the perfect way for us to learn how to approach this. So here's our game plan. First, we're going to listen to what the patient tells us, the symptoms. Then we'll see what we find on examination, the signs. We'll touch on the 2 classic ways patients can present. After that, we'll get into the gold standard test that proves the diagnosis, look at other supporting tests, and finally, we'll put it all together in Mr. Sharma's case file. Okay, first things first. Before you even reach for your stethoscope, before you order a single test, the most important thing you can do is just listen. Seriously, the patient's story will give you about 80% of the diagnosis. So, what are the classic complaints that should make your COPD senses start tingling? You know, the story almost always starts quietly. It's a cough. Most patients just brush it off as a smoker's cough. No big deal. Then they start producing some phlegm, or what patients call balgam. But the thing that really brings them to the clinic, the symptom that scares them, is dyspnea, what we call sans pulna, or breathlessness. At first, it's just when they climb a couple of flights of stairs, but over the years, it gets worse. Soon, just walking to the kitchen leaves them breathless. This trio, cough, balgam, and progressive breathlessness, that is the absolute classic signature of COPD. Now, for all the students listening, here's a super simple way to remember this. Just think, the patient has a problem with their BAG. What does that stand for? Well, B is for breathlessness, A is just and G is for gunk. That's the chronic cough and all that sputum. So if a long-term smoker comes to you complaining about problems with their BAG, your alarm bells for COPD should be ringing loud and clear. All right, so we've listened to Mr. Sharma. His story is pointing us strongly in one direction. Now it's time to actually examine our patient. What are the physical clues, the signs that can help us build our case for COPD? So when we look at Mr. Sharma, we might notice a few things right away. His chest might look a bit wider and rounder than normal. That's the classic barrel chest. It happens because the lungs can't get all the air out, so they stay overinflated, which pushes the chest wall out over time. And look at how he's breathing. See that? He's breathing out slowly through pursed lips. That's a clever unconscious trick patients learn. It creates a little back pressure that helps keep their tiny collapsing airways open just a bit longer so they can get more air out. It's a huge clue. Now, I want to talk about something really interesting. Clinicians used to describe severe COPD patients as falling into one of 2 categories. Now, in reality, most patients are a mix of both. But understanding these 2 extremes, the pink puffer and the blue bloater, is incredibly helpful for understanding what's going on underneath. So on one side, you have the classic pink puffer. Picture this person. They're usually thin, they're sitting forward, using all their muscles to breathe, and doing that pursed lip breathing we just talked about. Their main problem is emphysema, the destruction of lung tissue. They have to work incredibly hard, hyperventilating, just to keep their oxygen levels normal, which is why they stay pink. Then on the other side, you've got the blue bloater. This patient is often overweight, they have a terrible, gurgly, productive cough, and they have a bluish tint to their skin, or cyanosis. Their problem is mainly chronic bronchitis, clogged airways. They aren't working as hard to breathe, so their oxygen drops and carbon dioxide builds up. Okay, so history? Check. Exam findings? Check. Our clinical suspicion for COPD is now sky high. But in medicine, suspicion isn't enough, right? We need objective proof. And that brings us to the single most important, non-negotiable, gold standard test for diagnosing COPD. And that test is called spirometry. Now, don't let the name scare you. The concept is incredibly simple. We just ask the patient to take the deepest breath they possibly can, and then blast it all out as hard and as fast as they can into a tube. That's it. This simple test measures how much air they can blow out and, more importantly, how quickly they can get it out. The entire diagnosis of COPD basically comes down to this one magic number, 0.70. We look at a ratio. We take the amount of air the patient blows out in the very first second, that's the FEV1, and we divide it by the total amount of air they blew out in the whole breath, that's the FVC. See, healthy lungs can push out almost all the air in that first second, but in COPD, the airways are narrowed, so the air gets trapped and comes out much slower. If that FEV1/FVC ratio is less than 0.70, or 70%, even after we give them a puff of a bronchodilator to open their airways up, boom, you have confirmed irreversible airflow obstruction. That is the definition of COPD. Now, once we've confirmed the diagnosis, the next question is always, well, how bad is it? And spirometry helps us answer that too. This time we just look at the FEV1 by itself, and we compare it to what would be normal for a person of that age, sex, and height. Based on that percentage, we can stage the COPD from Gold 1, which is mild, all the way to Gold 4, which is very severe. And this is absolutely crucial because it helps guide our entire treatment plan. Fantastic. So spirometry has given us our confirmation. It's the star of the show. But to really get the full picture of what's happening, we need a good supporting cast. There are a couple of other tests that help us understand the extent of the damage and also help us rule out other diseases. A chest X-ray is one of those key supporting tests. We can't actually see the blocked airways on an X-ray, but we can see the consequences. We look for signs of air trapping. The lungs will often look really big and black, which we call hyperinflation. And on Mr. Sharma's X-ray, you can clearly see this. The diaphragm muscle, which should be a nice curved dome, has been pushed way down and flattened out by those overinflated lungs. It's a dead giveaway. Next up is an arterial blood gas, or an ABG. Think of this as a direct report card from the lungs on how well they're doing their main job, swapping gases. In the early stages of COPD, this might be totally normal, but as the disease gets worse, we start to see hypoxemia, which is just a fancy word for low oxygen in the blood. And in very severe disease, we can see hypercapnia, which is a buildup of carbon dioxide. Mr. Sharma's ABG shows some mild hypoxemia, and that directly explains why he's feeling so breathless. You know, this quote from the World Health Organization just says it all. It boils the whole process down perfectly. It's a two-step dance. Step 1, you suspect COPD based on the patient's story, the symptoms. Step 2, you confirm it with the objective proof from a breathing test, spirometry. Suspect, then confirm. It's that simple. Of course, every good clinician has to be part detective. We have to make sure we're not being fooled by a look-alike condition. We call this our differential diagnosis. The most common condition to mix up with COPD is asthma, but the key difference is that in asthma, the airway obstruction is usually reversible with a bronchodilator. In COPD, it isn't. Heart failure can also cause breathlessness, but the X-ray and spirometry findings will look totally different. So it's crucial to consider these other possibilities. All right, team, let's circle back. We've gathered all of our clues. We have the patient's story, our examination findings, and our investigation results. So let's put it all together now and formally close the case file for Mr. Sharma. So let's just recap his journey. Mr. Sharma, our 60-year-old smoker, presented with the classic triad of symptoms. Our exam showed clear signs of air trapping. We did a spirometry test, and his FEV1 to FEC ratio came back at 0.65, less than 0.70, which confirmed the diagnosis. We then looked at his FEV1 alone, which was 60% of what it should be, allowing us to stage him at Gold 2, or moderate COPD. And there you have it, a clear step-by-step path to the final diagnosis. So, we've given Mr. Sharma a diagnosis, but a diagnosis is never the end of the story, is it? It's really just the beginning. The truly important question is, what are we going to do about it? How do we create a plan to help him breathe better, to improve his quality of life, and to help him live longer? Well, that's exactly what we're going to break down in our next explainer. Thanks for joining the rounds today. Chalo, welcome everyone. आज हम बात करेंगे COPD मैनेजमेंट की. From A to Z, OPD से लेके ICU तक सब कवर करेंगे. ये आपके एग्जाम्स के लिए भी इंपॉर्टेंट है और रियल लाइफ प्रैक्टिस में तो है ही. तो ये है आज का प्लान. पहले सिवेरिटी असेस करेंगे गोल्ड स्टैंडर्ड से, फिर मैनेजमेंट की फाउंडेशंस और ड्रग्स की बात करेंगे, उसके बाद आईसीयू में हाइपोक्सिया कैसे मैनेज करना है वो देखेंगे, और लास्ट में प्रोएक्टिव केयर जैसे वैक्सीनेशन. सिंपल, लेट्स स्टार्ट. ओके, सो सबसे पहला स्टेप, पेशेंट आपके पास ओपीडी में आया है, आपको सस्पेक्ट है कि उसको सीओपीडी है या ऑलरेडी डायग्नोस्ड है. तो सबसे पहला काम क्या है, ये पता लगाना कि उसकी डिजीज कितनी सिवियर है, क्योंकि सारे मैनेजमेंट डिसीजंस इसी पे डिपेंड करेंगे. सो यही सवाल है. आपके पास एक पेशेंट आया है, कितना सीरियस है उसका सीओपीडी? इस सवाल का जवाब हमें क्लिनिकली ऑब्जेक्टिवली देना है, और इसके लिए हम यूज करते हैं गोल्ड गाइडलाइंस. ये हमें एक क्लियर कट फ्रेमवर्क देती हैं. ओके, देखो, ये टेबल पूरी सिवियरिटी को एक नंबर पे लाता है. FEV 1% प्रिडिक्टेड. और याद रखो, ये पोस्ट ब्रोंकोडाइलेटर वैल्यू है. पेशेंट को पहले ब्रोंकोडाइलेटर दो, फिर PFT करो. सो गोल्ड 1 यानी माइल्ड है FEV 1 80% से ज्यादा. गोल्ड 2 मॉडरेट है 50 to 80 के बीच में. गोल्ड 3 सिवियर है 30 से 50. और गोल्ड 4 वेरी सिवियर मतलब FEV 1 30% से भी कम. ये नंबर्स बिल्कुल याद कर लो. योर एंटायर ट्रीटमेंट प्लान इज बेस्ड ऑन दिस.
ऑलराइट, अब एक वेरी वेरी इंपॉर्टेंट एग्जाम ट्रिक, इसको नोट कर लो, वाइवा में बहुत पूछते हैं। डायग्नोसिस कंफर्म होती है FEV1/FVC रेशियो से। अगर ये लेस दैन 0.70 है तो मतलब ऑब्स्ट्रक्शन है, डायग्नोसिस डन। लेकिन सिवियरिटी कौन बताता है? सिवियरिटी बताता है FEV1% प्रिडिक्टेड। सो रेशियो फॉर डायग्नोसिस, परसेंटेज फॉर सिवियरिटी, इन दोनों को कभी मिक्स मत करना।
ओके, चलो अब मैनेजमेंट पे आते हैं। और सुनो, इससे पहले कि हम कोई इन्हेलर या ड्रग की बात करें, हमें इन चीजों पे फोकस करना है। क्यों? क्योंकि यही सबसे इफेक्टिव ट्रीटमेंट्स हैं, इन्हेलर से भी ज्यादा। एक भी इन्हेलर लिखने से पहले यह सबसे इंपॉर्टेंट चीज है, स्मोकिंग सेसेशन। ये अकेली ऐसी चीज है, द ओनली इंटरवेंशन, जो डिजीज के कोर्स को बदल सकती है, जो लंग फंक्शन डिक्लाइन को स्लो कर सकती है। बाकी सारी दवाइयां सिम्टम्स मैनेज करती हैं, ये डिजीज को ही मॉडिफाई करती है, इसलिए ये नंबर 1 है।
अब पेशेंट को स्मोकिंग छोड़ने के लिए कैसे बोले? इसके लिए ये 5 A's मॉडल यूज करो, बहुत इफेक्टिव है। पहले आस्क, हर विजिट पे पूछो। देन एडवाइज, क्लियर वर्ड्स में बोलो आपके लिए ये छोड़ना जरूरी है। फिर असेस, वो छोड़ना चाहता भी है या नहीं। अगर हाँ तो असिस्ट, उसकी हेल्प करो प्लान बनाने में, मेडिसिन दो। और लास्ट में अरेंज फॉलो अप, भूल मत जाओ उसको, फॉलो अप इज की। ये स्टेप्स फॉलो करोगे तो सक्सेस रेट बढ़ जाएगा। स्मोकिंग के अलावा ये हैं COPD केयर के पिलर्स। नंबर 1, पल्मोनरी रिहैबिलिटेशन। इससे पेशेंट की एक्सरसाइज कैपेसिटी, क्वालिटी ऑफ लाइफ सब इंप्रूव होता है। नंबर 2, न्यूट्रिशन। COPD पेशेंट्स में मसल वेस्टिंग, जिसको हम कैशेक्शिया कहते हैं, बहुत कॉमन है। गुड न्यूट्रिशन इज वाइटल। फिर पेशेंट एजुकेशन, पेशेंट को सिखाओ इनहेलर कैसे यूज करना है। 90% पेशेंट्स कलर टेक्निक यूज करते हैं। और हाँ, पोल्यूटेंट से बचना, ये सब ऑप्शनल नहीं है, दे आर एब्सोल्युटली एसेंशियल।
ओके, चलो अब आते हैं दवाइयों पे। आवर फार्माकोलॉजिकल आर्सेनल। आपके पास बहुत सारे टूल्स हैं, सही टूल्स सही टाइम पे यूज करना ही आर्ट ऑफ मेडिसिन है। लेट्स सी व्हाट वी हैव। ये एनालॉजी मुझे बहुत पसंद है और पेशेंट्स को समझाने के लिए बेस्ट है। सोचो, जो रेस्क्यू इनहेलर्स हैं यानी साबा, वो हैं फायर फाइटर्स। जब सांस की आग लगती है वो आके बुझाते हैं, क्विक रिलीफ। और जो मेंटेनेंस इनहेलर्स हैं जैसे लाबा और लामा, वो हैं सिक्योरिटी गार्ड्स। वो 24 घंटे ड्यूटी पे हैं ताकि आग लगे ही ना, प्रिवेंशन। तो चलो इनको डिफाइन करते हैं। साबा यानी शॉर्ट एक्टिंग बीटा एगोनिस्ट, एग्जाम्पल सैल्ब्यूटामोल। ये क्विक रिलीफ देता है, पेशेंट को सांस फूली, उसने साबा लिया, ठीक हो गया, सिंपल। फिर है लामा, लॉन्ग एक्टिंग मस्करिनिक एंटागनिस्ट, एग्जाम्पल टियोट्रोपियम। ये रोज लेना होता है, दिस इज द कॉर्नरस्टोन ऑफ मेंटेनेंस थेरेपी, एयरवेज को लॉन्ग टर्म खुला रखता है। वैसे ही एलाबी है, लॉन्ग एक्टिंग बीटा एगोनिस्ट, जैसे फॉर्मेटेरॉल या साल्मेटेरॉल। ये भी साबा जैसा ही है, बट इसका इफेक्ट 12 घंटे या उससे ज्यादा रहता है, लॉन्ग एक्टिंग। अब आती है बात ICS की, इनहेल्ड कॉर्टिकोस्टेरॉइड, जैसे ब्यूडेसिनाइड। ये हम हर पेशेंट को नहीं देते, ये तब ऐड करते हैं जब पेशेंट को बार बार एग्जैसर्बेशंस हो रहे हों, फ्रीक्वेंट फ्लेयर अप्स, यानी उसके लंग्स में इन्फ्लेमेशन ज्यादा है। अब जो हमारे सबसे सिवियर पेशेंट्स हैं, GOLD 3 या 4, जो डबल दवाई पे भी सिम्टोमेटिक हैं, उनके लिए हम यूज करते हैं ट्रिपल थेरेपी। इसमें तीनों चीजें एक ही इनहेलर में होती हैं, लाबा, लामा एंड ICS। ये बहुत पावरफुल कॉम्बिनेशन है सिम्टम्स कंट्रोल करने के लिए और मोस्ट इंपॉर्टेंटली एग्जैसर्बेशंस कम करने के लिए। ओके, अब OPD से निकलकर ICU में चलते हैं। यहाँ पे चीजें सीरियस हो जाती हैं। योर डिसीजंस कैन लिटरली सेव अ लाइफ। ऑक्सीजन, NIV और कब इंट्यूबेट करना है, ये आना बहुत जरूरी है। एक और क्लासिक एग्जाम क्वेश्चन, लॉन्ग टर्म ऑक्सीजन थेरेपी या LTOT कब प्रिस्क्राइब करते हैं, घर पे ऑक्सीजन कब देनी है और ये सर्वाइवल इंप्रूव करती है। इसके क्राइटेरिया बेस्ड है ABG पे। अगर PaO2 लेस देन और इक्वल टू 55 mmHg है या फिर SaO2 लेस देन और इक्वल टू 88% है, तभी प्रिस्क्राइब करना है। रट्टा मार लो इन नंबर्स का। अब एक क्रिटिकल ICU टिप, इसको दिमाग में छाप लो। अक्यूट एग्जैजर्बेशन में COPD पेशेंट का टारगेट SpO2 कितना होना चाहिए? It's 88 to 92%. Not 98, not 100. Never. हमारा एम है एडिक्वेट ऑक्सीजनेशन, मैक्सिमम नहीं। ज्यादा ऑक्सीजन देना डेंजरस हो सकता है, परमिसिव हाइपोक्सीमिया कहते हैं इसको। तो सवाल है, ज्यादा ऑक्सीजन डेंजरस क्यों है? इसके पीछे फिजियोलॉजी है। देखो, जो क्रॉनिक CO2 रिटेनर्स होते हैं, उनका रेस्पिरेटरी ड्राइव हाई CO2 से नहीं
बल्कि लो ऑक्सीजन से चलता है। उसको हम हाइपोक्सिक ड्राइव कहते हैं। जब आप उनको बहुत ज्यादा ऑक्सीजन दे देते हो तो ये ड्राइव खत्म हो जाता है। पेशेंट सांस लेना कम कर देता है। साथ में वीक्यू मिसमैच भी वर्सन होता है। रिजल्ट CO2 बिल्डअप होता है, रेस्पिरेटरी एसिडोसिस होता है और पेशेंट कोमा में भी जा सकता है। एक और ICU प्रैक्टिकल टिप, पेशेंट एग्जैस्परेशन में आया, ABG पे रेस्पिरेटरी एसिडोसिस है। आपका फर्स्ट लाइन ट्रीटमेंट क्या है? नॉन इन्वेजिव वेंटिलेशन या बाईपैप, बिना ट्यूब के ब्रीदिंग सपोर्ट। लेकिन पेशेंट को क्लोजली मॉनिटर करना है। अगर बाईपैप पे पेशेंट थक रहा है, GCS ड्रॉप हो रहा है या ABG में एसिडोसिस ठीक नहीं हो रहा तो वेट मत करो। डोंट डिले इंट्यूबेशन, टाइम इज क्रिटिकल।
चलो अब आखिरी सेक्शन पे आते हैं, द लॉन्ग गेम। COPD मैनेजमेंट सिर्फ आज के सिम्टम्स ठीक करना नहीं है, कल की प्रॉब्लम्स को प्रिवेंट करना भी है। और इसमें प्रोएक्टिव केयर, स्पेशली वैक्सीनेशन का बहुत बड़ा रोल है।
याद रखो, अक्यूट एग्जैजर्बेशन का सबसे कॉमन कॉज क्या है? रेस्पिरेटरी इन्फेक्शंस। इन्हीं की वजह से पेशेंट हॉस्पिटलाइज होता है और लंग फंक्शन तेजी से डिक्लाइन होता है। इसीलिए वैक्सीनेशन इज नॉन नेगोशिएबल, इस पे कोई कॉम्प्रोमाइज नहीं। एनुअल इन्फ्लुएंजा वैक्सीन, न्यूमोकॉकल वैक्सीन और कोविड बूस्टर्स, ये सब लगवाना जरूरी है। और मैं आपको इस आखिरी सोबरिंग थॉट के साथ छोड़ना चाहता हूँ। स्लाइड पे एक सवाल है, दवाइयाँ सांस लेने में मदद कर सकती हैं, पर जो लंग डैमेज हो चुका है उसे कौन रिवर्स करेगा? और इसका जवाब है कोई नहीं। द डैमेज इज डन, इट्स इरिवर्सिबल। हमारे ट्रीटमेंट सिम्टम्स मैनेज करते हैं, रिस्क कम करते हैं, बट दे कांट टर्न बैक द क्लॉक। इसीलिए इस बीमारी में प्रिवेंट